So exam 3 is this week, right? A lot of the content on the exam is the newborn, but there's some other things about high risk. So I'm trying to cover that in these 2 case studies that I made. Okay, is that you, Passion?
Yes.
Okay. All right. So we have a case here of a young lady. She's 28 years old. And don't pay any attention to this picture. It looks like she's got a nurse's uniform on. Anyway, this is supposed to be our client. She doesn't look too pregnant either. But anyway, she has a long history of illicit drug use, including methamphetamines, cocaine, heroin, and she presents to labor and delivery unit at 32 weeks gestation in preterm labor. Do you remember what the signs of preterm labor are? What are some of the client symptoms?
Continual low back pain.
Okay, low back pain, pressure, pelvic pressure, yeah. And sometimes contractions that kind of mimic Braxton Hicks, that tightening of the abdomen as if the baby's balling up, okay? She's very anxious, okay? And she asks the question, will my baby be okay? So how would you respond to that? Now, there is no right or wrong with this, okay? I'm just wanting you to kind of put yourself in the situation and ask yourself, how would you respond to her question?
Let us do what we need to do or run certain tests. I mean, I know you don't want to give a yes or no answer.
Right. You wouldn't want to say no, and you certainly wouldn't want to say yes, because you really don't know for sure. So what are some things that would help her during this time?
I would probably tell her that we would do everything we could to try to make sure that they receive the best care, and that we would, do some tests and things just to check things out, but that we would try to just do everything we could for her and try to make sure that she gets good care, her and her baby.
Okay. And so you've established a good rapport with your client by now as you're admitting her and talking to her. What are some other things you would want to know? Let me go back here. What are some other things you would want to know, knowing that her history?
When was the last time she used?
Yeah.
And also maybe how the previous pregnancies went.
Okay. Okay. Yeah, you could pull in her history a little bit, since other than, getting the current history, you really don't know about her previous pregnancies yet. So you could ask about that. When you ask her about drug use, you're going to not say, when was the last time you used? You're going to say, when was the last time you took a drug, or what drug did you take and when was it? So you want specific, okay? You want to be very objective, very, very specific, and to the point.
Can I ask you a question about that?
Yes.
So by you asking, what if the patient lies? So do you give them like some type of urine test or something, or are you just taking the patient's word on it?
Well, even if she lies, I think we would take that information, and as we go through labor and postpartum, we begin to see things. You're going to be collecting data. And if her baby begins to display withdrawals, she took something fairly recent. Okay. But giving them an opportunity to tell us which drugs they took and when is very important. Okay. Yes, we could draw a urine drug screen. We would need her permission, so she would know about it. So if we are asking her, we also need to inform her, can we get a urine drug screen? You need to get her permission. Okay. Need to be very transparent. So we talked about the symptoms that she might have of preterm labor. So if your nursing care plan with this client, one of the goals would be to prevent fetal injury, because knowing of her history, knowing that she's preterm, what are 3 interventions that you would plan to help prevent fetal injury?
Would prenatal care be one of them?
What did you say, Samantha?
Would prenatal care be one of them?
Okay, we're planning on interventions now for our client that's in labor.
Would prenatal care be one of them?
No.
Would
talking
fetal
about what-
monitoring be one?
Okay, so we do need to monitor the fetus. Oops. What 3 interventions do we usually provide to help protect the fetus during this point in time?
Would you give mom mag sulfate for the neuroprotection?
Okay, so that's one intervention. We need to go ahead and initiate a mag sulfate infusion to improve perfusion of the fetal brain. What
Would
else?
beta and then maybe antibiotics?
Okay, antibiotics and betamethasone. Absolutely, that's perfect. So if she's in labor right now, betamethasone is not going to do a whole lot of good right now, but we probably would go ahead and give it. Okay, good. So antibiotics, magnesium sulfate, and betamethasone. Good. So you're applying the tocometer, the toco reader, and the ultrasound to her belly. Okay, and the provider orders an ultrasound to be ordered. What labs would you anticipate at this point? What do you think? What kind of labs do you think you would order? That would be ordered?
If she started on MAG, wouldn't her potassium be and her white blood count?
Okay, so we're going to probably do a CBC and a chemistry, like a CMP, that kind of lab, yes. Urine tests, check urine cultures. Okay, so the fetal heart monitor shows a reassuring pattern. Okay, and this is just a whoops, I forgot when I'm on the slideshow, I can't do this. And so what do we refer to as what 3 things would you need to see to reassure you that the fetus is doing fine? Now, this is not on the exam in particular, but we're going through a case, and this is what we want to look for. What is one thing you would want to see on the fetal heart monitor?
Like a normal heartbeats, right, from 110 to 160.
Okay, so a normal fetal heart rate between 110 and 160. Good. What else?
Would variabilities be one?
Yeah.
What kind of variability? Remember?
Is it early variability?
Yeah. Head compression.
It's called
Early, late, and D cells?
No, it's called moderate variability.
Yes.
There's a 6 to 25 beats per minute change in that heart rate over a 15-minute interval. Okay, so variability. What else? Anything else?
Kick count.
Back cells?
Accelerations, yes, accelerations. We want to see some accelerations, yes. And the last one is more of a negative. We're not seeing any late or prolonged decelerations, okay? Okay, so you're reviewing the client's prenatal record, and it's verified that she has a drug history, okay? And she has sporadic prenatal care. She didn't always show up for her appointments. So what should you recognize or the nurse recognize as a potential risk for the client and for the fetus?
Late and variables.
We're not talking about heart rate patterns anymore.
Like, what is it? Congenital abnormality.
Abnormality.
Okay, so we might, yeah, she might not have gotten some ultrasounds done. She had poor history. What else can you think of might?
Respiratory distress.
Based on what?
Maybe like a low birth weight.
Okay, great. Low birth weight, excellent. Drug use, sporadic prenatal care, low birth weight, absolutely, excellent. That is one of the major things that you probably would see. So the client does admit to using cocaine 6 hours ago. So what are some risks you know that are associated with cocaine use during pregnancy, especially now that she's in labor?
It's a stimulant for the CNS for mother and baby.
So will it make the baby tachycardic?
Okay, a baby might be tachycardic because of the cocaine use. Okay, what else?
Is it placenta abruption?
Good, yeah, placental abruption, and there's one more I'm thinking of.
Previous?
Not that I know of, no. And this one probably is something you might not think about, but what about a precipitous labor? A very fast occurring labor, okay? 2 hours after admission, a male weighing 2,700 grams is delivered, okay? The nurse should recognize the labor as blank and be alert for signs of blank and blank. Okay, she delivered a male 2 hours after she was admitted. So what kind of a labor is that?
A precipitous.
Precipitous. So if you know your client's been through a precipitous labor, what should you be alert for?
Hemorrhage.
Postpartum hemorrhage.
Yes. Postpartum hemorrhage and
the some tearing.
Infections.
okay, infections and certainly lacerations of some sort. Yeah, some injuries, maternal in particular. Yes, there could be some fetal injuries as well. Okay. So she's asking now after her baby is delivered, she's anxious and she's asking if the baby's okay. Skin to skin is delayed. Why would you think skin to skin is delayed?
Baby respirations.
Okay. So this is a preterm baby. So she might have had some respiratory distress. That would be one reason, and usually the only reason that we would delay skin to skin. If baby's having trouble, mother's already anxious and she's scared and she's asking if her baby is okay. All right. So the newborn, in your assessment as a nurse, the newborn has blue tinted hands and feet, hypotonia, and a heart rate of 110. Oral suctioning causes a newborn to slowly withdraw and grimace. Respirations are irregular at 70 breaths a minute. This is 1 minute after birth. What APGAR would you assign?
7?
Actually, it's a 6.
Oh,
Right.
Respiration's at 70 is a little high, okay? And her withdrawing slowly with a grimace means the reflexes are a little slow, okay? And then, of course, the other two. Heart rate is okay. So what does this indicate?
You may need a little bit of assistance.
Yeah, the baby might have some retained fluid. Could have been a meconium aspiration, even though we didn't talk about it. Respiratory distress, okay, because of the immaturity of the lungs. What are some other signs of respiratory distress in a newborn?
Nasal flaring, retractions,
Grunting.
Grunting, yeah, good. Seesaw respirations. Okay. So the etiology of the respiratory distress then would be the prematurity of the baby, okay? The newborn is stabilized, and during skin to skin, the client asks if she can breastfeed her newborn. What's the nurse's response?
Yes, she can if it's on cocaine.
She can if what?
If she did cocaine within the past 6 hours, doesn't the American Associates of Neonates or whatnot say it's okay for her to still breastfeed?
Right. Right. No, we would not want her to breastfeed at this point.
Which drugs are they not allowed to?
Well, anything other than
Methadone.
a opioid antagonist. No, your text.
Methadone doesn't.
Methadone or Subutex, yes, we definitely want her to breastfeed. But any other medications, no. Any other drugs, no. Okay. Other than breastfeeding, what are other benefits of skin to skin?
Bonding.
Bonding, yes, bonding.
cardiopulmonary stability
Yep.
and
The
temperature
temperature.
regulation.
Okay, good. Okay. What do you need to accomplish with this baby, this newborn, within the first 2-3 hours postpartum?
Eyes and thighs.
Eyes and thighs. So we're going to put some, what do you mean by eyes and thighs, Naomi?
Vitamin K and
Vitamin K, and then the erythromycin gel in case the mom had gonorrhea.
Okay. Vitamin K. What do we give vitamin K?
The baby can't produce it yet, and it helps with the blood clotting.
Okay.
Factors.
Okay. Good. Okay.
So
we already discovered the what?
Erythromycin also.
Yeah, the erythromycin gel. Yes, in the eyes. So what are your priorities of client and fetal assessment during this time? We know that you did, we know that respiratory wise, this fetus is stable. Of course, we've mentioned watching for signs of hemorrhage. What else?
Their temperature.
Okay, why temperature?
So they're staying warm.
Okay.
This is for the, you mean for the baby or for mom?
Both.
Temperature also to monitor for infection.
Okay. What else?
The thermoregulation between the heat loss and their heat that they're producing.
Do we want to
Okay,
make sure that the mom is like bonding with the baby?
Okay, good. Yeah. So we're going to watch for the bonding.
Would we also check for hypoglycemia?
Maybe so. Yeah. With a newborn, with a preterm baby. Yes. Okay.
To make
What
sure that
else?
they're not experiencing the cold stress that newborns can get.
Yes. Okay. So yeah. So we're monitoring
the priority to make sure that the mom knows what like withdrawals looks like in the baby.
Okay, okay. So it was a precipitous labor too, so we do have to do a really thorough examination of mom, make sure she's not bleeding from any lacerations or anything. What else? What would you want to look for in a newborn?
Withdrawal symptoms.
Okay, what about in regards to the precipitous labor?
Hematoma.
Okay, so
A capital.
okay. So
name.
yeah, we're assessing for any injury. Okay, so you'd want to start with the head and work your way down. Just do a good assessment for any injury. That's what I was trying to get to. So while assessing the newborn at 6 hours after delivery, the nurse observes an enlarged firm area on the newborn's right parietal area. What are you suspecting? And what would you anticipate because of that?
Cephalotoma and hyperbilirubinemia.
Okay, so cephalohematoma, which is a localized area of bleeding in the soft tissue. And then these babies will develop because of the bleeding.
Bilirubin.
Yeah.
High bilirubin levels, yeah. So how do we treat high bilirubin?
Phototherapy.
Phototherapy, right? And we have to breastfeed baby constantly. So that's why they can poo
Every 2 to 3 hours.
Yeah, so a lot feed, right?
Yes.
Yes. Good. So your client calls out to the nurse station 8 hours after she's delivered. She's concerned about the baby. She says her baby is having trouble drinking from the bottle. You arrive and you recognize symptoms of withdrawal. What are some symptoms that indicate the baby's already gone through some withdrawals?
Like irritability, crying, constantly
High
crying,
pitch cry,
high pitch cry,
irritability, jitteriness,
Fragmented sleep.
Also the poor
Fragmented.
latch and feed.
Okay. Okay. Yeah. They don't have that coordination, that autonomic system coordination. Right. Right. Very hypertonic. The muscles are very rigid. Okay. So what kinds of things would you help her with?
swaddle the baby, so mother can hold.
make a nice dim area that was low in stimuli.
Yeah, dark room, quiet room.
Yeah. So if you provide less stimuli, go into the room and see what's going on in the room. If there's a lot of activity in the room, the TV's on or whatever is going on, you have an opportunity then to teach, reduce stimulus and darken the room and have her swaddle that baby and see if that will help the baby drink the bottle better. So we usually keep our newborns that have NAS longer in the hospital just to monitor them, especially if they're having a terrible time and we're needing to give morphine. So we talked a little bit about swaddling. What else can we help mom with during this time? Other than swaddling?
Holding the baby, like eat, sleep, and console, and teach her all the signs and symptoms and just being able to hold that baby.
Yeah. So yeah, and help her recognize something that might be causing worsening of the symptoms. Something is bothering her baby and reduce that kind of activity. Okay. So postpartum day 2, you're already beginning to see signs of jaundice in the newborn. What are you seeing?
Yellowness of the skin.
Okay.
Like
So
a yellow
the sclera of the eye.
Yeah. So you notice in this picture the extent of jaundice. So the high levels of bilirubin in the body. What you're going to see first is the yellowing of the head and the eyes. And it makes its way down the higher the bilirubin level gets. Okay. Do you remember what it's called when it gets so high that the brain has damage?
Does it start with a C or a K?
A K. It starts with a K.
I heard it on your review video earlier.
Connectorus.
That's it.
Connectorus.
I wouldn't remember that.
You wouldn't recognize it if you
If I saw it, I would.
Can you spell it?
K-E-R and K-E-R-N-I-C-T-E-R, I think. O-U-S.
Okay, that's fine. I can look it up like that.
Okay.
Thank you.
So interventions for the newborn with jaundice. Number one, we need to reassure mothers that it's a temporary situation and give her, the plan. This is what we can do. Make sure you're feeding the baby often. And then we could talk about what phototherapy we can use while the baby's in the hospital. There's so many different things that we have in the hospital. And then when she goes home, what can she do? Okay. She's complaining about her painful breasts now. What's going on and what should she teach the client?
Mastitis, maybe so we can put up warm compress and she can feed her baby more often. So that's why her breast is getting emptied.
But
Well,
earlier it said in there that it was
feed
a
the
bottle
baby.
feedal. I'm sorry. It said that she was bottle feeding. So you
Yeah,
can
we're
instruct
not
her to wear a
breastfeeding,
tight
right?
bra.
Be
Tight
engorgement.
bra.
Okay.
Engorgement. So yeah, she's got some engorgement going on. So what are your instructions?
The cabbage leaves,
Wear a
form-fitting
tight
bra,
for 72 hours.
no nipple stimulation.
Yeah, cold compress like cabbage leaves and ice. Keep them cold, no stimulation. Good. Good. Any questions about that?
So whenever it's a mastitis, she cannot feed her baby.
Mastitis. Well, if she was breastfeeding her baby, then we would definitely probably be seeing mastitis. Okay, so mastitis. So with the information I gave you, she's not breastfeeding, so we know it was probably engorgement. You had the disadvantage of not really assessing her and seeing what was going on. So if she had mastitis, what's the plan of care for mastitis?
Warm.
She can still breastfeed with mastitis, and instead of cold, you're gonna put warmth on there. You're still gonna stimulate. She can still breastfeed and all of that because it's of the breast tissue, not actually like where she's breastfeeding the child.
And an antibiotic.
And an antibiotic. She'll get some doxycycline, but warm compresses are going to be comforting. So keeping the breast empty is another thing. If it's too painful to breastfeed or she just doesn't want to, then she can hand express the milk to keep it from becoming engorged.
Okay.
Because we still want the breast to make milk. The infection will go away with antibiotics, and then she will be able to feel more comfortable about breastfeeding if she had not been on that breast. Okay. Any questions about any of that? Okay. Let's see here. I'm going to talk about something that I came up with at the last minute. And I will let you know some of this information is not stuff that you really have to know, but it's fascinating to me, and I haven't stayed caught up with it in the field yet. But let's talk about a client that you have that has HIV. Okay. So information about this client is that she did have preconception counseling before she wanted a baby. She knew she had HIV. So we do a lot of testing with these clients, and we put them on the antiretroviral medications prior to pregnancy, because we want that virus amount to be as low as possible before she gets pregnant. So antiretroviral medications are safe in pregnancy because the benefits outweigh the risk. Okay, I don't think they've studied it much, the effects of antiretroviral on a newborn or on a fetus, but hang on just a minute. So it's recommended by ACOG and many other organizations to pre-treat before the pregnancy to get that leveled out, and then to maintain throughout the pregnancy. If a client wasn't pre-treated, then they will start antiviral medications during the pregnancy. And there's a lot of stuff out there now that I would really like to take some time to read. So your client has been receiving antiretroviral therapy during her pregnancy. So the goal is to achieve and maintain a viral suppression to undetectable levels to reduce the risk of intrauterine transmission or perinatal, in other words, labor also and delivery. Okay. What we often see with HIV mothers is small babies. Okay. That drug use, that HIV status, small for gestational age. You know that HIV is a virus that attacks the immune system. Okay. So clients with HIV, if they have high levels of the virus, it's almost considered AIDS at that point. But their immune system is compromised. Okay. So they're at risk for a lot of things, even if they're not pregnant. Okay. So at 32-week gestation, our client had a fetal ultrasound, and it showed the baby at the 10th percentile in growth. In other words, small for gestational age, a small baby. Okay. And that's probably because of the HIV. Maybe the nutrition isn't what it needs to be. So then the healthcare provider plans twice weekly visits, and we'll do a non-stress test and a BPP. So we're watching for how baby's thriving. And then we're going to induce labor if that baby's growth drops down to the 5th percentile. Okay. So the cause we're assuming is because of drug use or because of the HIV, poor nutrition with this baby. So at 36 weeks, everything's going fine. Baby's still thriving, okay. But she calls the office and says that her water broke. And so we admitted her to labor and delivery. And even though this slide shows some slight contractions, she wasn't really having any contractions. Okay, so what do you call it when the water breaks and there are no contractions? What do you call it when the water breaks?
When water breaks and there's no
Rupture of membranes.
Rupture of membranes. What if they rupture and mom's not in labor within the hour?
Pre-rupture of membranes.
So premature rupture of membranes. So we have a client with a gestation of 36 weeks, and the water broke, and she's not in labor. So this is called premature, preterm rupture of membranes, okay? And there's a lot of risk associated with this, especially for a client whose immune system is compromised. What do you think that is?
Infection.
Infection. So infection is probably what caused her water to break. Okay, because if there's an infection in that amniotic fluid, it makes that membrane very weak, and the water will, the membrane will actually rupture. Okay, and she's not in labor. So now we're concerned about infection. Okay, let's see, where am I? Okay, so what client medical history and current data concerns you? Okay, what other information do you need to know to help plan for this client and her baby? Okay, this is labs, and I just threw these in here, okay, just so I can explain to you. Hemoglobin, 10 grams per deciliter, not uncommon during pregnancy. Okay, little low, okay. White blood cells are low, okay, which is uncommon in pregnancy, but because of her HIV status, her white blood cells are low. So she doesn't have anything to fight infections, okay? Her platelets are a little bit low, 60,000, that's kind of low, but we're not gonna want to give her steroids for this like we would with ITP. When platelets are low in ITP, we would probably give a low dose steroid, but we're not going to do that. Does anybody know why?
What was the question again?
Why wouldn't we want to give a steroid to this client because her platelets are so low? This is a very complex case, but I thought it would be fascinating for you. See, normally, if we have a client with ITP, immune thrombocytopenia purpura, at a platelet level of 60,000, we would probably give a low-dose steroid to help preserve those platelets. But we're not going to give a steroid to an HIV patient because it reduces immune function. Okay, they're already compromised, so we're not going to do that. Her fibrinogen is about normal. Her sodium looks fine. Her potassium is normal. Glucose looks fine. Her liver enzymes, AST and ALT, are slightly elevated. Why would that be?
Because of the HIV?
Yeah, because of the HIV, okay? Urinalysis shows that she has an infection in her urine. Her leukocytes are elevated. There's nitrates in her urine, and there's some blood in her urine. And the blood in the urine is probably from low platelets as well as an infection, okay? All right. That's a little deeper than what you really need to understand. Okay.
So whenever
let's
we
go
give
on.
her any kind of a steroid, does that help to maintain the level of blood platelets, or is it elevate? How does those help steroids?
Steroids, we actually reduce the effect of the immune system.
Okay.
Yeah, steroids would stop the immune system from destroying the platelets.
Okay, perfect.
Yeah, and we don't want to do that. We can give her fresh frozen plasma, which would have platelets in it for her. Okay, that would be a much safer thing to do. Okay. All right. So let's review our client again. Okay. What do we know about her? She has HIV, and she's been treated with antiretroviral throughout her pregnancy. So it reduces the transmission of HIV to the fetus. She had early rupture or a preterm rupture at 36 weeks. We have a small fetus, SGA, small for gestational age. We have some abnormal labs. So the risk factor, the number one risk factor here is what?
Excessive bleeding.
But we can always give her platelets.
IV to the fetus or the baby?
Infections. Okay, so infection is our number one concern with this client. So we need to be very diligent about making sure that not only is she getting antibiotics, but we're doing some standard precautions, right? Washing our hands, wearing gloves, not allowing mother and baby or baby to be in contact with anything infectious. Okay, so we have her in labor right now. Okay, we induced her and we've got her at 3 milliunits a minute and things are working just fine. And we talked about reassuring fetal heart patterns, and that would be heart rate between 110 and 160, no late decelerations or prolonged decelerations. We want to see some accelerations. So what are some things that you would see during labor if infection is evolving?
Do you see fever?
Okay, so mother's going to have a fever. What else?
Tachycardia?
Tachycardia. And one more thing? Fetal tachycardia, right?
Oh.
Okay, so what's infected?
Amniotic fluid?
Okay, and what do we call that?
Chorioamnionitis?
Okay, chorioamnionitis, yes. So what else would you, in your assessment, would you find besides fetal tachycardia, fever, maternal tachycardia?
Like maybe the tenderness for tenderness of a uterus.
Yeah. And what else? She's leaking fluid.
The same, the amniotic fluid will be like purulent, right?
Yes.
Foul smelling.
Yeah. So it's gonna be obvious in the fluid. Okay. So what do we do for this?
Antibiotics?
Yeah, penicillin is the drug of choice. Okay. All right. And this is just some info. You don't have to know this, but it's just some information for you if you're interested in this at all. And I did read that if we provide antiretroviral therapy prior to and during pregnancy, it really lowers the risk of the transmission to the fetus, especially if those viral loads are low. In other words, the amount of virus in our body, if we can keep it low, then there's significant difference, okay? Vaginal delivery is very appropriate in this situation, but I also read that if it's higher, it's C-section would be more appropriate, and I'm not sure why, other than they can absolutely control the blood mixture, okay? Also, some interesting information is that some of the antiretrovirals that we use for HIV have a effect on uterotonics. It makes them, it potentiates them, okay? So in other words, exaggerated response for uterotonics. So if we're given antiretrovirals to our mother and she's postpartum and she's bleeding a lot, we have to be really careful with methergin because it can make her blood pressure even higher because of those HIV medication. Okay. All right. So we need to continue antiretroviral throughout pregnancy, labor, postpartum, and on. We're also going to treat the neonate for antiretroviral treatment. And I'm not sure how long that goes on postpartum, if they take it out 6 months or what they do. So you're doing your head to toe assessment on your newborn. Mother is doing very well. Baby is doing well. Bonding with mother. She is happy that baby is doing okay. And you're getting ready to do a really good detailed head to toe assessment on the male. Okay. You notice epispadias. Is that something that is normal? What is that? It's epispadias.
When the urethra is on the dorsal side?
Yes. So when the opening to the urethra is actually on top of the penis and not at the very end. So you have hypo, which is the ventral area, and then you have the epi, which is the dorsal area, or the other way around. I'm sorry. Anyway, so you notice that, and that is not something that's normal. Okay, so you need to notify the pediatrician. And so we have to postpone circumcision until they do that repair work they use the foreskin to do the repair work. Okay. So what other genital assessments should you perform on a male? What else do you want to see? Well, baby males have a penis and they have scrotum, right? Do you want to assess the scrotum?
Yes, for hydrocele, something like.
Okay, so hydrocele. So sometimes newborn males have a small hydrocele, just collection of fluid around the testy. And most times it resolves on its own. It's not usually a problem. One way you can assess it, though, is to transilluminate.
Light, right?
Yeah, to see if it's just fluid. Okay. So it's usually resolved on its own. What about a female? What might you see in a female?
A bloody vaginal discharge.
Okay. Okay. What else?
Breast buds.
Swollen too.
Breast buds. And maybe a little swelling. Okay. So estrogen levels are high during pregnancy. So that does influence the effects on the newborn. So females, they'll have little breast buds and they'll be a little swollen. And they might have some smegma. It's called bloody discharge, which is very common. Okay. So what are we going to teach mom going home about care for her baby? What are some important discharge things we want to think about? And there's no right or wrong answer here.
No.
So, Passion, you have a client and that's getting ready to go home. She's done very well and she's going to go home, and her baby, and actually she's already home. She's come back to the hospital to get her baby, and you've been teaching her all along. What do you want to reinforce? What does she need?
Does she need? Should she still be on antibiotics?
She might be. Yeah. Good point. She might be on some antibiotics still because of her infection during labor. So you need to give her instructions about the antibiotics, right? Lots of fluids, make sure she's eating well. Okay. This is very broad, but it helps you kind of think.
They're not supposed to breastfeed. They're not supposed to breastfeed or nothing, right?
No, she's not breastfeeding. She's feeding bottle. Baby's doing fine on a bottle.
Wet diapers for the baby.
What?
for the babies, for the healthy, we have to count baby's wet diaper, like if baby is doing good.
So yeah, we want to make sure the baby's urinating well. 6 to 8 wet diapers a day means that the baby is probably getting everything he needs. Yes. What about bathing the baby and stuff like that?
On my study guide, I have written down that it's important to teach new moms about the temperature of the baby and about the respirations and the normal ranges that should be in, about how to bulb suction, the different feeding patterns with formula and stuff, and knowing the signs that your baby might be hungry. Like she said, the elimination, the 6 to 8 wet diapers a day. You can teach her about the different types of stools that babies can have. You can teach about sleeping, positioning, and holding the baby. Car seat safety is a big one, especially since she's coming to pick her baby up for the first time. So this will be the first time riding in the car. Different baby, cord care, especially. And then
what about cord
CPR
care? What
and when to
about
call
cord
the
care?
doctor.
What about cord care? How do we teach a mother about cord care?
Keep it dry.
Keep it dry.
You're supposed to hold the diaper down, like keep it.
Keep
it dry. Keep the diaper below the cord so that it can heal in the open air. And it also prevents irritation from the urine or like pain that it can cause the baby if the diaper's over it.
And if it gets dirty, just rinse it with some warm water, but then keep it dry. Yeah. Okay. Good. Those are good things.
And to let the stump fall off on its own.
Yeah. Good. We can also provide mother with information on rehab facilities, and hopefully we've been doing that through the pregnancy, and we can certainly provide that and follow-up care and stuff like that. Since we don't know the HIV status of the newborn, they will be testing the newborn into the next few months and probably the next year or two, just a screening for any possible signs of HIV contraction. So we need to make sure we teach mom about hygiene and infection control, crowd control. In other words, not taking her baby out in the crowd. The same thing that she would be doing to keep her infection rate down. So we need to do the same for the baby. Okay. And then certainly follow up prenatal or pediatrician care and seeing her specialist. This was something different, okay, that I did. And it's a lot of this isn't something that you have to know, but it still goes back to the same principles of preventing infections, teaching our clients what's important for them to know, giving them information that they need for their particular circumstance, okay? So those were the 2 case studies that I wanted to share with you tonight. I know you all can do this. You had good feedback and good input in this. And is there anything else you want to go over before we end the session?
I would like to go over an example for the dosage calc for the heparin question. I would love it if we could do a practice one of those.
Okay. All right. Let me do this then.
Do you do dimensional analysis for yours? Because that's the only way I know.
No, I don't.
Okay. It's okay. I can still follow along.
Okay. Let's see here. So remember that in trying to pull up I wonder if I have a whiteboard. There we go. Can you see my whiteboard?
Yes. Yes.
Okay, so this is heparin. So it says 25,000 units and 500. Okay, let's see if I can make this work. Let's see here. I'm not used to doing this. I want to be able to write on here. No, I can't. Forget that idea. I got to practice that. So usually heparin, how is it usually prescribed?
Bolus?
How's it? How is it usually prescribed? So usually we do a bolus dose, right? Bolus dose based on the client's
The weight.
the weight in kilograms, right?
Yeah.
Okay. So, and then it's typically 80 units per kilogram for a bolus dose. Okay. So let's say we gave that. That's easy enough, right? 80 units. If she was 100 kilograms, that would be what? 100 times 80, that would be 8,000 units. Okay. But usually after that, we do a maintenance. In other words, continuous infusion. And let's say our IV bag had 25,000 units. Always write out units of heparin in it. Okay. And I'm going to do this. And then I'm going to do that. And we're going to say 1,000 D5W. Okay, that's our solution. If the order says to give your client 1,800 units per hour, that's the order. Okay, so you have to figure out how much of that solution contains 1,800 units. So 25 this is how I do it to make it simple for me. So what I usually do is I'm going to cross multiply. You need, so this is what we have. We have 25,000 units per liter. What we want is 1,800 units, right? That's how many we want. That's how many that's ordered. So now we have to figure out what this number is down here. Right there. So, and that's what we call proportion. Okay. So how do you get the answer here? How do you calculate that?
The 25,000 divided by 1,000 times 18. Or no? Oh, I see what you mean.
Oops. That's how you do it. So when you calculate that out, 1,000 times 1,800 and divided by 25,000, you'll get your answer, right? Because what happens is the units cancel out, and your answer will be in mLs. And then that would be your hourly rate. So what's the answer? Anybody got the answer?
72.
72 mLs per hour. Okay. I don't know. I didn't check. So it's mLs per hour, right? So 72 mLs is how much of that solution contains the 1,800 units. So that's our rate. Did that answer your question? Somebody who asked me about that? Everybody's quiet. Did that answer your question, or did that make it worse?
It didn't make it worse. I just don't understand how to do it that way. So I'm just gonna look up some videos and stuff.
Oh,
It's okay. Thank you for helping. I just it took me so long to be able to understand the math. And for whatever reason, the only way that it works for me is with dimensional analysis.
Okay. Well, and that's good because that's a safe way of doing it. Okay.
So I have a way of doing it that's similar, but just a simple formula I always use, and it's D over H times Q. So your dose on hand divided by, or your dose that you need divided by H, which is what you have on hand, and then times it by the Q, which is quantity. Because I did that way and got 72 as well.
Yeah,
so that's kind of like a simple plug-in.
You flip it over. Yes. Yeah, flipping it the other way. Yeah.
So what would be considered the quantity in that?
What would be considered what?
Okay.
The quantity?
Was that volume?
Volume, yeah.
Oh, okay.
Lauren, yes, you could look it up. Let's see. Did I give you Dr. Brown's? It's kind of late for that now. You take your exam tomorrow, Lauren, don't you? Yes.
Yes, ma'am, at 3. But one of my classmates told me that I was talking to her a little bit earlier because we go to the same campus and stuff. And she told me that I should watch like the last little bit of Professor McBride's like 2-hour long video, and that goes over it. So I'm planning on doing that once we get done.
Oh, do you have that? Because I have that video if you want me to share.
Yes, I think that you posted it in the announcement things for us. So I'm just gonna go over there and see if I can find it.
Okay. If not, let me know so I can give it to you.
Okay, yes, ma'am.
All right. And another, what she has, Professor McBride has, is the answer to the OB calculations. And one of those is a heparin question. And I'm sure she does it in dimensional analysis for you. You want me to send that one to you?
Yeah, that'd be great.
Okay, I'll do that for you.
Okay, thank you.
You're welcome, Lauren. Anybody else need anything?
No, ma'am.
Okay, all right. Thank you all for coming. I know this group will do much better. I shouldn't say much better. We'll do well on this exam because this is a group that has reached out to me for help. You know, it makes a difference. It really makes a difference. And so I'm excited about you doing well and doing well in OB.
I'm excited too.
Me too.
Yes. Thank you so much for coming, okay?
Thank you. Have a good night.
You too. All right. Do you have another question? Naomi, do you have a question?
I'm just looking over the notes from your video earlier, seeing if I had anything. Can we go over one thing real quick?
Yes.
Is that okay? The modes of heat loss. So I have evaporation is when the baby's wet and then loses heat when the water evaporates. Conduction is when they come in contact with something like a cold scale, cold, something like that. Convection is like a draft from the window or a fan or something going. And then radiation. I have loses heat by being near an object. What exactly does that mean? Like, what's an example of that?
So if they're near a radiator, if they're near something that's cold, not touching it and not a draft, but if it's close by, that's going to pull heat from the baby if it's cold.
Okay.
If it is really warm, just like if you were sitting in your living room or your den or something and you had a fireplace going and you had your newborn, the heat, you can feel it radiating from the fireplace. Okay. And that sort of thing.
Okay, so it's more of like if there's heat nearby.
Yes, or cold nearby.
Okay.
Yes.
Okay.
Yes.
I think I watched your video yesterday, but then I watched it again today to take notes on it.
Okay, good.
I think I understand the bilirubin anemia a lot better.
Good.
So I think I'm good. I think the heat losses.
Yeah.
They're confusing. I'm having to find a way.
Yeah, they are. And I think pictures do a lot for that.
Okay. Thank you.
You're welcome, Naomi. Bye.
Bye.